Well, good day and thank you. My name is John Marshall. I'm speaking to you from Toronto, where I'm a professor of surgery and intensivist at St. Michael's Hospital in the University of Toronto. I want to share my disclosures for this presentation. They include both commercial and academic disclosures, as well as the acknowledgement that this talk is coming to you from traditional Indigenous territory that the City of Toronto now rests upon. I'm going to speak about the evolving perspectives on the hypothesis of the role of the gastrointestinal tract in critical illness. In its contemporary iteration, it goes back really to the origins of critical care and to the work of Jacob Fine, who was a surgeon from Beth Israel Hospital in Boston, who in the 1950s and 1960s undertook some seminal studies that established a role for something that he called an intestinal factor in the pathogenesis of hemorrhagic shock. This factor was subsequently determined to be endotoxin, or at least endotoxin was identified as one of those factors. But it set the stage for an understanding that events occurring within the gastrointestinal tract could significantly impact homeostasis in critically ill patients. My engagement in this field began in the 1980s when I worked with Jonathan Meekins, who originated the phrase, the gut, the motor of multiple organ failure, and in conjunction with John Border, who was a surgeon intensivist from Buffalo, there was a great deal of discussion and ferment about the potential roles that the gut might play in driving the clinical phenomenon of sepsis in critical illness, and particularly that phenomenon when it occurred in the absence of clear evidence of invasive infection. A number of different explanations came to light. The work of Edwin Deitch and Carol Wells showed very, very nicely that in multiple circumstances that are common in critically ill patients, the normal flora of the gastrointestinal tract became altered, and that altered flora could be absorbed into the body intact and cultured from mesenteric lymph nodes or from portal venous blood. The organisms were the same organisms that dominated in ICU-acquired infection. And so we undertook a study that looked at the correlation between the organisms that could be isolated from the upper gastrointestinal tract and those that could be isolated from invasive infections. We found that the common flora of the upper GI tract in ICU patients was the same organisms that we saw in these nosocomial ICU-acquired infections, particularly Candida, the Enterococcus, Pseudomonas, and coagulase negative staphylococci, at significant concentrations, and typically a dominant organism. The average number of species per isolate here was 1.8 per sample. But what was particularly striking is that those patients who had proximal gut colonization with Pseudomonas, coagulase negative staphylococci, or Candida had a significantly higher rate of invasive infection with those same microorganisms, suggesting that they were entering the body from the gut, either through the process of aspiration or through the process of translocation across an intact gastrointestinal barrier. So that was the notion of the gastrointestinal tract in the 20th century, that viable bacteria and endotoxin could be absorbed from the gut, and that could cause invasive infection, and that we might not see that invasive infection because it was occurring in locales such as the mesenteric lymph nodes that we couldn't really sample. As we have learned more in the 21st century, we're realizing that that may be a first approximation, but there is a much more sophisticated way of looking at the dynamic interactions between the human gastrointestinal tract and health. We know that we live on a planet that is largely microbial. 560 billion tons of carbon are maintained in microorganisms, and it's thought there are somewhere in the vicinity of 1 billion different species of microorganisms on the planet. They're far more numerous than we are, and their impact on every aspect of every kind of life on the planet is profound. You can see how much knowledge has accrued recently. Publications on the microbiome were relatively infrequent in the 20th century. They have skyrocketed in the 21st century, and with that, a significant shift in how we understand host microbial interactions. We know, for example, that being colonized with bacteria is normal in a state of health. The skin is colonized by 1,000 different species, the oral cavity by about 700, and the gut by about 500 species, or 5,000 species in a normal state of health. 3 times as many genes as there are in the human organism, and about 10 times as many cells. Moreover, these bacteria exert profound influences on normal health and development. In the absence of a microbial flora, the microvasculature of the intestinal villi is poorly developed. When you conventionalize a germ-free mouse, you get full, exuberant growth of microvasculature, and even simply associating the gut with Bacteroides will induce the same kind of effect. So bacteria are actually stimulating the growth of blood vessels in the host. And we know now that under normal circumstances, the microbiome is quite stable, but that it is altered in disease states, and that those alterations play a role in the pathogenesis of disease, whether it is cancer, obesity, non-alcoholic fatty liver disease, or diabetes. This slide shows a healthy human intestinal microbiome in the lower panel, which is dominated by the blue genera of firmicutes and relatively few of the red proteobacteria. When a patient becomes ill and is admitted to an ICU, those proteobacteria, which include the common organisms of ICU-acquired infection, overgrow and become the dominant species. And what you see in critical illness is both a significant overgrowth by pathogens such as aerobic gram-negative bacteria and Enterococcus and coagulase-negative staph, but also a substantial loss of bacterial diversity. There are ways that this can be targeted, and we are now rethinking the process of selective decontamination of the digestive tract, not as a way of sterilizing the gut, but rather of preserving the indigenous flora, the firmicutes that and anaerobes that normally serve to prevent overgrowth with pathogenic organisms. And it's quite clear on the basis of more than 50 randomized controlled trials that the use of this technique, which suppresses that abnormal overgrowth, is associated with a reduction in mortality and a reduction in the severity of organ dysfunction. There is currently an ongoing, a large multinational trial, the Sudoku study, evaluating SDD in Canada, the UK, and Australia, New Zealand, and hopefully within the next year or two, we will have insight beyond the results that have to date largely been restricted to a few countries in Europe. Another approach to supporting the indigenous flora is the use of probiotics or synbiotics. This was a paper looking at the use of synbiotics, which are microorganisms plus microbial products, and it showed that you could prevent neonatal sepsis in rural India through the use of probiotics or synbiotics, a simple, inexpensive intervention with a significant public health value. There are a number of small randomized controlled trials that have suggested that probiotics can reduce the rates of ventilator-associated pneumonia in the ICU. The point estimate here is on the side of benefit, although the N of patients recruited is really quite small. And we've just completed a study led by Deborah Cook in Hamilton, the PROSPECT trial that has looked at Lactobacillus rhamnosus GG as a means of preventing ventilator-associated pneumonia in ICU patients. About 2,500 patients have been randomized. Data analysis are ongoing, and I suspect will be reported before the end of the year. Now, finally, I just want to look at another aspect of the role of the gastrointestinal tract, and that's its capacity to become colonized by organisms in the environment. Acinetobacter baumannii lives in water, and it's a common contaminant of tap water in hospitals, and it can be passed to humans through flushing nasogastric tubes or diluting feeds. We had an outbreak in Toronto a number of years ago of Acinetobacter baumannii, which was linked to the hospital water supply and ultimately eliminated by stopping the use of flushing nasogastric tubes with tap water, and further of cohorting dirty ventilator circuits. So there are multiple places in the management of critically ill patients where they're exposed to the ICU water supply, including hand washing and washing the patient. And it's important, I think, as we move forward to recognize that this may be a mechanism that we can translocate organisms from the environment to the patient's GI tract, where they can then cause invasive infection. The future is uncertain, but there is increasing interest in the somewhat distasteful concept that fecal transplantation may actually play an important role in the management of disease. This has been evaluated in the treatment of Clostridium difficile colitis, and there are case reports now on the use of fecal transplantation for patients with multiple organ dysfunction. We are, I think, a long way away from turning this into a acceptable and effective treatment, but I think it is indicative of the way our thoughts about bacteria are changing. These were put very nicely by Joshua Lederberg, who suggested that we really need to change our thinking from thinking of microorganisms as an enemy to be defeated to seeing them as a part of ourselves and optimizing the way that we live in symbiosis with them. That principle applies generally, but it applies all the more urgently to patients who are managed in the intensive care unit. Thank you very much for your attention to this talk.